of this. You may have the genes that predispose you, but if you do not work out, you do not take care of yourself, then it's given. You'll actually get type 2 diabetes. So you can delay the development of type 2 diabetes or avoid it completely by ensuring that you are, working out and eating well.
Okay. Yes. Maybe then that leads to the question, is there a way of finding out that I'm predisposed to diabetes? Can I know that I have some recessive gene that is
so that you prevent it?
Yes, so that I know how to,
Yes, and as I said, a lot of studies have picked out a number of genes.
Yes.
For type 1, of course, we already have genes that have been, found out and then in record. And you find that some countries that, because of the resources that they have, they can actually do the screening. Okay, they can screen the genes. They can also screen what we call the autoantibodies. Okay, so if you find that a child or an individual has these positive autoantibodies or positive genes that are likely to lead to type 1 diabetes, then there is a way of knowing that it's just a matter of time. For type 2 diabetes,
good morning, good afternoon, a good day to all our viewers, and welcome to Ascendant Hope. And for those who may be joining us for the first time, Ascendant Hope is a program that brings stories of hope, stories of encouragement, stories of people that have gone through challenges in life, but they have, through their faith and confidence in God, they have been able to come through. So we want to welcome you once again to another episode that is going to inspire you and also give you a lot of information. So welcome. My name is Christine Kamau, and I have my co-host today with me,
Ivan Jawaini. It's a pleasure to have you back. We have been processing a lot and we have more stories to bring you. Today we talk about lifestyle diseases. Some of us may not be aware probably of the way we are living and how it's supposed to affect us in the long term. We have an expert in the studio with us today, Dr. Phoebe Wamalwa, who is an endocrinologist who is going to talk to us about diabetes. Sometimes we think it's not in my family, it can't catch me, but we want Dr. Phoebe to tell us more. Dr. Phoebe, welcome. Maybe you can tell the audience a little bit about yourself before we dive into the topic of today.
Okay. Thank you, Eva. Thank you, Christine, for inviting me. It's actually a pleasure to be here. My name is Phoebe Wamalwa. I'm a pediatrician and I'm also a pediatric endocrinologist. What does this mean? It means that first and foremost, I treat children and adolescents, and I went further ahead to specialize in endocrinology. And when we are looking at the field of endocrinology, we're basically looking at issues to do with hormone disorders. We are looking at diabetes. We are looking at growth disorders. If you have a patient who is not growing as tall, or a patient who is growing too fast, or a patient who is adding weight too much or is not adding weight, or any problem with the thyroid, ovarian issues, adrenal issues. So basically, that's what endocrinology pertains. And I think I'm so glad to be here to talk about diabetes. This is really my passion. I deal with diabetes in children and adolescents, but also, of course, these patients will grow up to be adults. So definitely it cuts across the entire lifespan. So besides being a doctor, I'm a wife to one husband. I'm a mother.
Good to know.
And I'm a mother to 3 children. All of them are teenagers. And I'm a born-again Christian. So I'm really, really happy to be here. Thank you.
Welcome. Now, let's talk about diabetes. You've said a lot of things. I think you deal with the entire body system, so to speak. But let's focus on diabetes. Maybe help our audience understand exactly what is diabetes. When do we say that you have diabetes?
So, definition of diabetes. What is diabetes? So this is a condition where there is persistently high glucose levels in the body. And it could be as a result of a deficiency of a certain hormone in the body, which we refer to as insulin. Or it could be because of resistance to the action of insulin, or it could be both. So a patient can have both resistance or both resistance and insulin deficiency. So diabetes can occur in children. It can occur in adolescents, in young adults, and even in older people. So briefly, to just classify the types of diabetes that we have type 1 diabetes, we have type 2 diabetes, we have what we call gestational diabetes, and then we have other specific types that I'll briefly just describe them for our sake.
Okay, maybe before...
Sorry, let me just jump in. Maybe before you go into breaking down the different types of diabetes, I'm just wondering about, you spoke that you specialize in diabetes in children and adolescents.
Yes.
Is there a difference in the diabetes that can be in a child and one in an adult? Or diabetes is across? Because when you say that you specialize with treating children, does that mean you cannot treat an adult? Is the diabetes different when it's in an adult, or?
Yes, that's a good question, Christine.
Yeah.
So that's why I was actually going into the different types. But when you look at diabetes in children and adolescents, we mainly talk of type 1 diabetes. Because if you get a young, a child and an adolescent or a young adult, there's a 90% chance that this patient could be having type 1 diabetes. But a few of them can develop type 2 diabetes because of lifestyle changes, because perhaps somebody is overweight or obese. Adults are mainly getting type 2 diabetes.
And you'll tell us.
And I will tell you the difference.
Type 1
yes.
and type 2.
Yes,
okay.
So adults mainly get type 2 diabetes. But remember, type 1 diabetes can still affect adults. Okay, so it just cuts across.
Right.
Okay?
Right.
Yeah.
All right. Maybe at this point, it's where you tell us what's the difference between type 1 and
type 2 and the other types.
Yes.
Okay. Yeah, so type 1 diabetes is the type of diabetes that happens when we do not have enough insulin in the body. And what is insulin? Insulin is a hormone that is secreted usually by an organ that lies just behind the stomach, and that is the pancreas. So the pancreas secretes a number of hormones, and one major one is insulin. So what does it do? It basically pushes the glucose from the blood into the cells. Once the glucose enters the cells, it will be broken down into energy that now helps the body to run physiologically. So without that energy, you'll find that somebody now becomes very weak and all that. So that's type 1 diabetes. That is where we have deficiency of insulin because there is no secretion from the pancreas. The pancreas has been destroyed. Type 2 diabetes usually starts with resistance to the action of insulin. So initially you have enough insulin that is getting secreted by the pancreas, but then with time, you'll find that because of a number of issues, it could be overweight, okay? It could be sedentary lifestyle giving you what we call metabolic syndrome. So you find now there's resistance to the action of insulin. If it's not identified early enough, then there'll be exhaustion by the pancreas, because the pancreas will keep on secreting insulin to a point where it does not now secrete sufficient amount of insulin. So at one point, this adult may have both resistance to action and also deficiency of insulin. So that's why you'll find some individuals are put on pills to swallow and also insulin injection. The third type of diabetes is what we call gestational diabetes. And this is the type of diabetes that mainly affects pregnant mothers. So you find a mother before pregnancy was normal, didn't have diabetes, but once they get pregnant, now they start having sugars rising in the body. After delivery, it takes a short time and the sugars normalize. Okay? In as much, but of course we have a few that may persist with diabetes later on. Then the fourth category are now the specific types. These are what we call genetic or monogenic type of diabetes. So a patient is born with a defective gene that regulates insulin secretion. And this can affect even neonates. as early as 28 days or even 1 week of life, you find the sugars are not getting controlled. Or it can affect an adolescent much later. So these are monogenic type of diabetes. And then we have another type that happens when you take certain chemicals or drugs that affect the pancreas, or they can increase the resistance to insulin action. So for instance, if you are asthmatic and you keep on swallowing steroid medication, that one can actually give you what? Resistance to the action of insulin. Okay, and other medication that are normally used in treatment of disorders like cancer, immunosuppressants. Yeah, so we basically have those general types of diabetes, but I'll be happy to.
Okay. Maybe just to backtrack a bit as we go to Christine. You talked about where we either are not secreting enough or we are resisting.
Yes.
So what would be first, you say the pancreas could be destroyed.
Yes.
What would cause the pancreas to be destroyed?
Very good question.
Yes.
And that's a question we actually get a lot from our patients.
And is it, sorry, before you answer, is it destroyed,
Yes.
or not functional? Because when
Yes.
you talk about destroyed, it means it's not functioning at all.
Okay. Yeah, so allow me to answer that. So when we are talking about destruction of the insulin secreting cells in the pancreas, it basically just means that. And why does it occur? This occurs in type 1 diabetes, and it's through a process where the body attacks its own cells, what we call autoimmune disorder. Auto means self. Okay, so there are some kind of patients who are born with certain genetic predisposition, meaning that at one point, if they have any insult from the environment, whether it's a virus or a certain chemical, it can now start off that process of self-destruction of the cells. Okay,
Right.
and some of the cells that are prone to self-destruction from the autoimmune conditions are the insulin-secreting cells in the pancreas, the ones we call beta cells. Okay. The thyroid cells also are prone to autoimmune destruction, and even the cells in the adrenal gland, okay, and certain cells on the skin. So those are some of the autoimmune disorders that normally are prone to self-destruction.
So in that case, when you are getting diabetes type 1,
Yes.
often it's not something within your control. It's not a lifestyle issue.
Yes.
Okay.
That's
Exactly.
for type 1.
Yes, that is type 1. So type 1 is not within your control.
Yeah.
Okay? Because it can affect any individual at any point of life.
Right.
It can affect a 1-year-old, an 8-year-old, a 30-year-old, okay? Simply because you are born with certain genetic predisposition to undergoing the self-destruction of the cells.
Okay.
Question, Dr. Wamalwa. You have said that diabetes 2 is caused by lifestyle, maybe the way somebody lives or what they eat and stuff like that. I've seen people that live healthy or try to live healthy and they still get it. So please talk to us.
Yes, and
What
we wonder,
happens?
is it really lifestyle?
Yes.
So type 2 diabetes, unfortunately, we have a lot of research and studies that have been going into it to really get to know what exactly causes it. Initially we used to think it's sedentary lifestyle. Somebody is not working out, he's not eating well. And we thought that is the only reason. But we have also found out that it has to do with a lot of genetics. And if you look back in certain families, you'll find that there's a lot of clustering of type 2 diabetes in one family. You may find an auntie who has type 2 diabetes, a cousin, a grandfather, a mother. So there's a lot of clustering because of certain genes that predispose to getting resistance to insulin. But having said that, lifestyle is a great contributor to the development of this. You may have the genes that predispose you, but if you do not work out, you do not take care of yourself, then it's given. You'll actually get type 2 diabetes. So you can delay the development of type 2 diabetes or avoid it completely by ensuring that you are, working out and eating well.
Okay.
Yes.
Maybe then that leads to the question, is there a way of finding out that I'm predisposed 2 diabetes? Can I know that I have some recessive gene that is
so
likely
that you prevent it?
Yes,
from
so that I know how to, yes.
Yes, and as I
protect
said,
myself.
a lot of studies have picked out a number of genes.
Yes.
For type 1, of course, we already have genes that have been, found out and then in record. And you find that some countries that, because of the resources that they have, they can actually do the screening. Okay, they can screen the genes. They can also screen what we call the autoantibodies. Okay, so if you find that a child or an individual has these positive autoantibodies or positive genes that are likely to lead to type 1 diabetes, then there is a way of knowing that it's just a matter of time. For type 2 diabetes, number one, look back. How is your family history? Okay? If there's a lot of clustering in your family, then you are able to run some genetic testing. Okay? So if you find that you have consistent genes that point towards type 2 diabetes, then there's a high likelihood that you may actually get it at one point. Yeah.
Okay, can I walk into a hospital and just say, I need some genetic testing for diabetes?
Unfortunately, genetic testing is a genetic test is a very expensive test.
Okay.
Oh.
It's very expensive. It's not easily available. Currently in Kenya, we are referring the samples out
Out of the
South
country.
Africa, to India and many other places. Yeah, but we hope that sooner we shall actually get labs that are able to run that. But of course, now we are talking about just having a check, okay, an annual check, full check, okay. I mean, just doing that random blood sugar or fasting blood sugar. It's something that is very simple. It can be done at home or in a clinic, health center, okay. And if you find that the sugars are now beyond the range, the recommended range, then you need to start on interventions that could either be medication or nutritional advice or just lifestyle modification. Yes.
Another question, Dr. Wamalwa, is can we say diabetes is among the diseases that are classified as chronic, terminal? If someone gets, because there's a lot of stigma
Yes.
around diabetes, and the minute people hear you have diabetes, everybody goes like, oops, okay. So you seem like one to be pitied, one to be, people don't understand you and things like that. So why is there so much fear and stigma around diabetes? Is it a life-threatening, or you get it and that's it, you're done for the rest of your life?
Yes, again, it takes us back to the classification. Type 1 diabetes, if you get it, it means that over 80% of your pancreatic cells have been destroyed and it cannot be reversed. Having said that, we have a lot of studies that are ongoing in different parts of the world to just basically see if they can do transplantation of the cells from different, places. It could be human to human transplantation or animal to human transplantation. However, without that, of course, it's terminal, meaning that you have to keep on now getting injection of insulin from outside because now your body is not producing insulin.
So it's lifelong.
So it's lifelong. Okay, that's the message
That's
we pass. Type 1.
Okay.
Type 2 diabetes, we have a lot of talks and studies on reversal of type 2 diabetes, especially if that diabetes came as a result of a clearly sedentary lifestyle. So if you put in a lot of effort in making sure that you're active, you lose weight, there are chances that the medication you're taking can be reduced in terms of the dosage, okay?
Right.
And to some extent, you may be off the drugs. But I'm saying off the drugs with a caveat. You have to work closely with your physician so that you can be guided. Otherwise, most of the type 2 diabetes, again, it's a chronic ailment. Okay, so what we normally encourage patients is, please manage it. And what is our end goal? Our end goal is to ensure that at all times, the sugars are within the recommended normal ranges. If they are not within the recommended normal ranges, your organs will start getting destroyed. Okay, which organs are these? We are talking about the kidneys. You can easily get kidney failure, okay, end up on dialysis. You can get heart failure. You can get stroke. You can lose your eyesight, okay? And you can get nerve damage. So management entails ensuring that we have proper control of the glucose levels in the body. For patients who are born with genetic defects that affect insulin secretion, those ones, again, there's nothing you can do. We are talking about gene therapy, but it's really not within our reach, okay? So those are patients, again, who will be on lifelong treatment. Yeah. Gestational diabetes, as we said, the one that affects pregnant mothers, most of the mothers after delivery will go back to normal.
Right.
But we have to advise them, again, to live an active life and ensure that the diet is complied with. Yes.
You know, you've mentioned the heart as you're talking about the organs that are likely to be affected. And there seems to, I don't know, is there a correlation between diabetes and hypertension? Because it seems like someone who has diabetes often ends up hypertensive.
Right.
Yeah.
Yeah. There's a strong correlation.
Yeah.
Why is it? Why do we have a correlation? It's because if you have diabetes, chances are that you most likely may be overweight or obese. Okay? Most likely your cholesterol levels may be abnormal. Okay? And those are risk factors for hypertension. And again, diabetes, if it's not well managed, as we said, it will affect the kidneys. If the kidney gets affected, definitely it will affect the blood pressure. So the blood pressure will rise. Okay?
Right.
If that diabetes is not well managed, it will affect the heart. Okay? When the heart gets affected, plus the accompanying vessels, there's resistance to the blood flow, and as a result, the blood pressure rises. So there's a strong correlation. If you go to our usual dialysis units, you will find this is a patient who has both diabetes and hypertension. Okay.
And ended up with kidney failure.
Yes. So either kidney failure came in between or it came after the two.
Okay.
Yeah.
Wow.
Oh, wow. Wow. I'm so glad that Dr. Wamalwa, you're able to shed light because you get very many different views about diabetes and everybody seems to have views. There are actually people who have the theory that the minute that your readings are within the range, stop medication, stop everything. And would you advocate for that, or you'd rather, even once the readings are the same, you'd rather someone continues with the medication that they have been given?
A very good question. And we see that a lot amongst our patients, where once they get a normal reading, they say, I'm healed. And they stop taking the medication.
Yes.
But remember, our goal is to ensure that the readings are within normal. So once we achieve the normal readings, it means the drugs that you are on are working. So continue. You do not stop. Your doctor can only advise you to reduce the dose if perhaps your sugars are going way lower, okay, than the recommended ranges. Or he may advise that you raise the dose if the sugars are persistently above the recommended range. But if they are within, please do not stop the medication.
Okay.
You need to continue with that to avoid complications.
Okay.
Yeah.
Okay, I'm just wondering then, what would be the symptoms of diabetes? At what point do I suspect I have diabetes and I need to go to an expert?
Yes, very good. So diabetes manifests with high blood glucose levels. And let me just start by just explaining how those symptoms come about. If we do not have a functioning insulin, there's resistance to its action, or perhaps we do not have insulin, it means there's a lot of circulating glucose in the blood. This glucose will have to be removed from the body through the kidneys. And it does not come out as powder. As it comes out, it drags along water. Okay? So you'll find a patient who has diabetes has frequency in urination because glucose is coming out and it's dragging alongside water. Okay? So that's number one sign. Number two, as you are frequently urinating, you're losing water, so your body will generally become dehydrated. As you become dehydrated, you will definitely feel thirsty. So you want to drink a lot of water.
Yes.
So this is a patient who is going to the loo to pee But it's also taking a lot of water.
Okay.
And you look at them, they are dehydrated because they're losing all that. Now, if you do not pick these symptoms and make a diagnosis of diabetes and start treating, this patient may develop worse symptoms. Because remember, glucose is not entering the cells. And the cells, the body is very smart. It will look for alternative forms of energy. So what are these alternative forms? It will look at getting energy from the fat cells, energy from the muscle, energy from the stored glucose in the liver. So all this will be broken down. So when the fat cells get broken down into fatty acids, they'll form acidic compounds that we call ketone bodies. Okay? So these are acidic compounds.
Ketone bodies.
Yes. So this will accumulate in the body. And if they reach a certain level, you'll find this patient now starts hyperventilating, okay, has labored kind of breathing, because now you have to excrete excess acid or carbon dioxide, okay, that has accumulated. If you do not pick it out and treat, this is a patient who can start having abdominal pains and vomiting because of the acidity of the ketone bodies. Again, if there's no intervention, this is a patient who will go into coma, lose consciousness. Okay? Now, because we are breaking down the fatty acids and the muscle, the patient will lose weight. Okay? So you'll find in type 1 diabetes, they present with increased urination, increased thirst, loss of weight, and general weakness. In type 2 diabetes, unfortunately, it's not as dramatic as type 1 diabetes. It takes a long period of time
To present.
Right. Okay? So you find somebody has rising sugars, but it will reach a point where now the sugars are too high that they start having symptoms of increased urination and increased thirst. But the weight loss may not be as apparent as type 1 diabetes. And that's why you normally have delayed diagnosis in type 2 diabetes. So at the point where you're making that diagnosis in type 2 diabetes, most likely the organs have started developing complications.
Wow.
Okay? Yes. Yeah.
So does type 2 diabetes put the patient at a higher risk in terms of the threat to life than type 1?
Because it means it's just creeping on you.
Yeah.
And you're not even aware, you know?
Oh, a good question. But I'd want to answer it this way. Actually, type 1 diabetes is a greater threat to life.
Okay.
Type 1.
Because if you do not make a diagnosis of type 1 diabetes timely, that patient, because of lack of insulin, the body will start breaking down the fat, okay, production of ketone bodies. Ketone bodies will bring this patient into a diabetic emergency. It becomes an emergency. So they'll present with a lot of vomiting, abdominal pains, loss of consciousness, and if there's no ICU and proper management, you will lose that child.
Wow.
And why is this extremely important? It's because in our setup, if you get a child who is having difficulty in breathing, any basic healthcare worker will say this could be pneumonia. And if they don't remember to check the sugars, they may never make a diagnosis of diabetes. So that child dies and they certify on the death certificate that the child died of pneumonia. Okay? If the child presents with vomiting in our setup, you will think it's malaria. Okay? Or perhaps it's just gastroenteritis. So you'll focus your efforts in treating malaria that is actually not there. And because you've not checked the sugars, you lose the child. If the child presents with loss of consciousness, you'll actually think of meningitis. Okay? So you treat meningitis, you've not checked the sugars, you have lost the child. If the child presents with weight loss, you might think this is malnutrition. If this child lands in the nutritionist's hands and they have not checked the sugars, again, there will be mismanagement and then you lose the child. So for me, the greater threat of life is towards type 1 diabetes. For type 2 diabetes, it's more of complications and a strain to healthcare because these are patients who will now require dialysis because of the kidney failure, hypertension, and all that.
Wow, listening to you, I'm thinking, really, any patient who shows up in hospital needs to be tested for diabetes.
Thank you.
It
And
sounds
this is
like
actually
it.
this is
Sounds
actually
like
the
it.
message
Yeah.
that we want to pass across.
Uh-huh.
And it's good it's come out of you, not me.
Yeah.
Because it's something that we've been advocating for. And when you look at the current pediatric protocols by the Ministry of Health, there's a statement that says any sick child that comes in the hospital, remember to check the sugars. The only problem here is our culture, our health-seeking culture, is when a child gets sick, people will start going to the chemist first. They say, my child has, they're given this trial and
Self-medication.
error, self-medication.
Yes.
Okay? So as a result, there's a lot of wastage of time.
Yeah.
So by the time this child is now ending up in a proper hospital to do the blood checkup, perhaps this child has already gone into diabetic emergency, and now we have, a possible complication and even risk of death. Yeah.
Oh, wow. Now, there's this school of thought about the kind of diet that a person that has diabetes should be having. And, of course, many people are advocating for don't eat carbs, don't eat beans, don't eat... I know you're not a nutritionist, but I'm sure you can at least give some guidance. I'm sure even our audience want to learn that. If somebody is diabetic, somebody has come to you and they are presented that.
Yes.
What advice would you give them?
Okay.
Like from today, don't eat this, don't eat. Because I think there's a lot of mystery. There's a lot of...
There's a lot of myths around that.
Yeah.
And allow me again to break it bit down into type 1 and type 2. Now, type 1 diabetes, you remember the cause? It was insulin deficiency.
Yes.
Okay? And it affects mainly children and young adults, the youth. So the general recommendation in type 1 diabetes is we do not have restrictive diet.
Or they can eat whatever.
Because these children need to do what? To grow. Their brain is still developing. They're still gaining milestones. They have to enter puberty like any other without any delay.
Right.
So if you restrict the diet, they will not grow normally. So what we normally advise them is, our end goal is to get normal sugars. So how do we do that? Get a normal, healthy diet as recommended by your nutritionist, but it has to be balanced with the insulin you're taking. So let's give an example. In the morning, you wake up, child is diabetic, and they say, Mommy, I want to take a pancake, a boiled egg, and maybe a cup of milk. So the nutritionist will have taken the caregiver through approximating how many carbohydrates are contained in such a plate. Okay? And then they will tell her, with this amount of carbohydrates, you need 2 units of insulin or 4 units of insulin, depending on your age and also on your weight. So it's all about balancing the carbohydrates and insulin. But the general recommendation is the plate must be healthy. Your vegetables, your proteins, your carbohydrates, your nuts, your water, and your milk. Okay? And a healthy snack in between. Let's move to type 2 diabetes. Majority of type 2 diabetes because of lifestyle diseases. And at most of the time when we get them, they have metabolic syndrome. Allow me to describe what metabolic syndrome is.
Sure.
This is where a patient has a number of lifestyle diseases occurring at the same time. May have hypertension, may have high glucose levels in the body, and they may have what? Increased cholesterol. Okay, and they're also overweight. So that is metabolic syndrome. So you will find now this gives us a complex, disorder. It's actually a complex disorder to manage. That the food that this patient needs has to be tailored towards loss of weight. It must be tailored towards reduction of cholesterol. And also, it should allow the patient to move normally without losing energy. So we recommend complex carbohydrates. What are complex carbohydrates? These are carbohydrates that upon ingestion, they take a long time before getting absorbed. So that means that they maintain sugars at a stable level. Okay, let's give an example. If you were to get a a brown bread, truly brown, not colored. Okay,
Thank you for that.
a true brown slice of bread.
Yes.
Compare it with white bread. If you take this white bread, the sugars are likely to rise up suddenly and drop suddenly. But if it's a brown bread, the sugars will rise gradually, okay, at a stable level, and they will take time to drop.
So the
So which
whole
one?
meal.
The whole
The
meal
whole
is
meal
actually
bread,
the one that
Yes,
is
yes.
now recommended.
Okay.
Okay? But we do not advise that they omit carbohydrates from their diet because you need energy. So the recommendation, work with your nutritionist, let them do the diet plan for you to be able to take care of that metabolic syndrome holistically. But for children, we are saying there's nothing called diabetic diet. For patients who have type 1 diabetes, there's nothing called diabetic diet. Balance carbohydrates and
The
insulin. And monitor the growth of the person.
child.
Yes.
Okay,
Could you give us an example of complex carbohydrate? I'm sure maybe there is somebody in the audience who wants to know. Probably they have type 2.
Yes.
And they want to know. You said we can have
Whole
I
meal
can
bread.
take,
Yes.
What else?
Yeah, what
Yeah,
else?
so
apart from whole meal?
complex carbohydrates are what we generally refer to as brown foods. Okay? If you are a lover of ugali and you're in Kenya, then you would want to either take brown ugali, or you can use these ones that we just do in a portion meal.
And that is
Okay?
not sifted.
Okay, the one that is not highly processed. For rice, if you're able and you can afford, you can take brown rice. Okay, but I don't want to go into studies that have shown the differences. The difference is very minimal. But if you can afford brown rice, very good. Brown, please, a brown bread, ensure that it's actually truly wholemeal bread.
Brown ugali?
Yeah, brown
Like
ugali, wimbi. Then, of course, the traditional foods, the ngwashe, the ndumas.
Sweet potatoes.
Okay, the sweet potatoes, yeah.
Right.
So these are foods that are highly recommended. If you are to be given a choice for breakfast, and you have your sweet potatoes there and arrowroots and bread, white bread, then you will definitely choose the arrowroots and potatoes, and then add your vegetables there and take a protein. It's always important to take a protein.
Right.
Okay. Beans are both proteins and carbohydrates, so they can still raise the sugars. So it's good to know that for a patient who we want to bring down the sugars, do not imagine that beans are just absolutely proteins. Yeah, they also have carbs.
Okay.
Yeah.
Okay, let's talk about
Oh, wow.
patient care. One has been diagnosed with diabetes, they are on treatment. Of course, you've told them about the diet and all that. The insulin. You're talking about taking insulin. How does that happen, and how do I control it as a patient?
Okay.
Yes.
Let me paint a picture here. You have a child or an adolescent who has worked in the emergency unit, has symptoms of diabetes, and the sugars have been taken. You make a diagnosis of type 1 diabetes. You have to admit this patient, whether the patient is stable or not. Why? It's because the patient must undergo what we call multidisciplinary team management.
Okay.
We need a clinician on board. This is a person who will prescribe the right amount of insulin. You need a nutritionist, talk about the diet. You need what we call a diabetes educator, very important person. This is a person who will take through the patient on just explaining what diabetes is, what type your child is likely to be having, and how to inject the insulin. Okay?
From home?
From home.
Oh, wow.
And remember, insulin injection for type 1 diabetes is 4 to 5 injections per day. Okay? And
wow.
this is accompanied by monitoring of sugars. So you'll find that at the end of the day, we have so many pricks in a day. Okay? So this diabetes nurse educator has to tell them the rationale as to why we have to have multiple injection of insulin. The sites, okay, where to inject, how to dial that dose of insulin, how to store insulin, okay? How to correct the low sugars, how to correct the high sugars. Because if they do not learn this, then they can easily die at home in sleep, okay? And then, of course, for school-going children, they need to be told what to pack every day they go to school.
I was going to ask about
okay?
children who are going to
Yeah.
school, yeah.
Yes, management has to occur at home and also at school. So we have to get in touch with that teacher and now tell them, this is a child who has been diagnosed with diabetes and this is what they'll be doing. So they go with what we call diabetes management plan, okay, explaining what needs to be done. And this is the work of a diabetes educator in collaboration with the clinician and the caregiver, okay? This is a patient who will want to go on trips. So what must the patient carry or do on the trips to avoid complications? What about parties, birthday parties? So all this is done by the diabetes educator together with the doctor. Then we have a very crucial member of the team, and this is the psychologist.
Okay.
The psychologist is a very important. Can you imagine? You have carried your child who is perhaps having difficulty in breathing. You take the child to the hospital and you think it's pneumonia. Okay? So after 2 days, the child is improving. You're making calls at home. My child is getting well and we are about to be discharged. Before discharge, you're called and you're told your child has diabetes. You're shocked.
Yeah.
Okay?
Yeah.
You're shocked. And the second thing you're being told, your child will require insulin, and insulin only comes in form of injection. So the mother is wondering, so who will be giving this injection? And then she's told it's you. And then she's told, you know what? It's not just one injection. It's four injections in a day.
Oh,
Wow.
Stuff
And
for a
she's
mom.
like, for how many days am I going to give this? And you're telling her it's lifelong. What do you think will happen to that mother?
Wow. It's
She'll
very
break down.
traumatizing.
So we need a psychologist on board to walk through this mother all the way even after the child has settled at home. And of course, we can also not do without a social worker because they work hand in hand. We have to check the environment at home. For type 2 diabetes, again, they still require the same multidisciplinary team because right now we are recommending that insulin needs to be initiated as early as possible, even for adults with type 2 diabetes, in as much as they're using other pills. So you also need this team to support them. The support environment at home is extremely important. You do not want to tell this person that you're not going to use sugar in your tea. And then you're seated on the same table at breakfast, and you guys
You're hipping your sugar into your tea,
3
and
spoons.
it's very
Yes.
Especially
and,
with a child.
and that child is actually there
And they can
observing
see
you
you do
guys.
that.
Yes. So the home environment must also be supportive. We tell the caregivers and the entire family we tell them, please live as though you also have diabetes. By so doing, you'll be supporting this other patient that you have.
Thank you for raising that, because I was going to ask how the support system at home is likely to be. I think you already answered that for me.
Yeah, I'm just having this thought. In our present situation in Kenya, you've talked about different medical personnel that are required. Are all hospitals equipped with this personnel? Because you've mentioned a number of medical personnel that need to be present at every diagnosis and at every... Because again, we need to think about, are we creating enough awareness about diabetes? Are we, you've talked about diabetes educators, you've talked about counselors, you've talked about someone actually taking them through that to talk to the caregivers. Is that being done?
Yeah, so unfortunately, we are a resource-constrained country. We have made guidelines, and I did participate in creating some of these guidelines. They were launched last year. And we clearly, of course, stipulated that we must have a multidisciplinary team in every level 4 and 5 and tertiary hospital. Okay? But what is the reality on the ground? Level 5 hospitals have the entire team, okay, but not, of course, at one place. You'll find that one psychologist in the hospital is running in different departments. Level 4 hospitals may not have the nutritionist. They may only have a clinician and perhaps a nurse who has been trained in a diabetes education. So we are basically also advocating, and thank you for this platform because it also acts as an advocacy platform.
Yes.
We have to raise our voices and tell the government, look here, if we want to reduce strain on healthcare expenditure, we need to ensure that we create enough empowered healthcare personnel that are ready and available, and they can take care of these illnesses accurately to avoid complications. Because if we do not do that, these are patients who will go into kidney failure. How much are we spending on dialysis per patient? It's extremely a lot of money. But how many patients have kidney failure in Kenya? Many, okay? Many. So it's easier to employ and prevent the complications than wait till you wherever get to the complication. The other advocacy area, and Christine, you really raised up something very important, awareness.
Yes.
Awareness cuts across. Right from the community level. We are telling everyone in the community, if you see a patient who is having frequency in urination, increased thirst, weight loss, that's a patient who likely has diabetes. Please advise them to go get tested and be treated. If you see a child or an adolescent who is vomiting and has labored breathing or is having confusion or loss of consciousness or weight loss, this is a patient who could have diabetes. Please advise them to go get tested. So those are the simple messages we are passing to the community. To the healthcare workers, we are telling them, please do not misdiagnose. Do not miss out a diagnosis of diabetes. And misdiagnose them with common childhood illnesses or patient illnesses. That glucose strip only costs around 50 to 100 shillings, and it can save a life. So let's just get used to testing sugars whenever we have sick patients. To the policy makers, let's ensure that we equip our hospitals. We equip our hospitals with human resource, with the infrastructure that is required. Because if you get that child or a patient with diabetic emergency and requires an ICU, and perhaps in the public sector, that ICU can only be gotten in Kenyatta Hospital or Kenyatta University, you'll find that child can die in your hands, okay? Because we do not have enough infrastructure. So we just need to ensure that we have allocated enough expenditure on health, so that the health system is compact and it's working well.
Wow, thank you. Thank you
so
much, Dr. Phoebe Wamalwa. I think our viewers have benefited immensely from this. Christine, you would agree with me.
Absolutely.
And we want to say asante sana in the language that we understand most.
Karibu.
And also, I like the advocacy you've done. I hope the government of Kenya is listening, and the fact that we really need our hospitals to be equipped. Healthcare workers, Dr. Phoebe, I think from your speaking, one would rather test and not find diabetes than not test it and miss it. And even for us, taking good care of ourselves and being cautious. I didn't think that if you're passing urine frequently and you're taking water, you think, it's because I'm drinking a lot of water. We would think that there is a problem. So I think we all have a role to play. From myself, looking after my own self, looking after the people in my home, the government playing their part, the health workers playing their part, and maybe we'll have a healthier society. So thank you so much. The Lord bless you for coming.
Thank you for coming.
Yes, Christine, you can wrap this up for us.
Yeah, so we are grateful viewers, and I'm sure that we have learned a lot. We've had stuff that probably we did not know before, and we are very grateful to Dr. Phoebe Wamalwa for coming and sharing this with us. And we just want to ask you to, let's be cautious. I think like Eva has said, let's just take this thing seriously. Don't just make assumptions. Don't just read things on the internet. There's a lot of school of thought that is going on around. And I think it's important just to go to a health facility and talk to someone that is a specialist, because then you're able to get the right information that you want. And I think from what she has said, there is hope. Yeah, there is hope. And maybe just as we shut this down, maybe Dr. Wamalwa, you can look at that camera and just tell a viewer who has diabetes, just give them one word.
Give them hope.
Just give them hope.
Yes.
Just one word.
So the fact that you have diabetes it doesn't mean that this is the end of your life. In fact, you really, really need to be glad and thankful to God that that diagnosis was made, because you could actually have died before the diagnosis is made. So please take care of yourself, manage yourself in terms of the diet, the activity, and follow the instructions given to you by your doctor without fail. And you know what? It can be done. We've had children who have patients who have survived with type 1 diabetes from as early as 5 years, and we have seen them growing to be judges and magistrates. At 80 years, they're still working. Okay, so it's not the end of life. So take care of yourself so that you can take care of the society, and we are here to support you.
Thank you.
Thank you.
That
Thank
wraps
you so
it up
much.
for us.
Yeah.
Subscribe, follow. We are coming back with more content. Thank you very much.
And bye-bye
Bye.
from all of
Okay,
us.
bye.
Yes.